So you have six, you just need one more. Good morning, Eddie.
Good morning.
Eddie from EDH.
Yeah,
Yes.
Good morning.
Good morning.
Hey, Catherine, did you get something from Dr. Sam saying maybe because of her family situation that maybe she won't be here?
no, I did not receive anything from
Okay.
doctors.
Yeah, we heard from, I think it was Elliot and Noah. So knew that Noah was gonna be able to join us today too.
Oh, no, it is not.
Yeah.
Noah and Elliot are not going to be
Yeah,
here.
so we need Portia, Dr. Sam, Sherry, or Mustafa.
Okay.
Sherry, let me call Sherry.
Oh, that'd be good, Jaja. Thank you.
I'll call Sherry and Mustafa.
Good morning, everyone. We are just waiting a moment here until we have quorum to begin the meeting. But thanks for hopping on and joining us.
You may just need one.
Martha, we took synchronized sips of coffee.
All morning.
Sherry will be joining momentarily.
Great.
Awesome.
Mustafa had a family emergency, but will be joining us in 5 minutes.
Thank you, Jaja.
Okay, yeah, well,
All right. Morning, everybody. Thank you so much for joining us and for being here today. I'm going to actually pass it to our chairperson, Jaja Floyd, to get us started with a welcome roll call and our theory of change.
Well, welcome everyone. Today is our coordinated entry meeting, May 28th, 10 o'clock. So happy to see y'all all here and survived our Memorial Day weekend. Catherine, can you call roll, please?
I will. Devin,
Here.
Eddie,
Present.
Martha.
Present.
Portia, and Dr. Sam. Kelsey,
Present.
Jaja,
Present.
Sherry,
Here.
Finn,
Present.
you have 7 members present and 4 absent. You have met quorum.
Great.
Thanks so
Thank you
much,
so much,
Catherine.
Catherine.
You're welcome, both of you.
I'm gonna round this with our theory of change, and then I will pass the baton off to Tom. Our theory of change, if we create a homelessness response system that centers people with lived experience of homelessness, then we will be able to respond to need and eliminate inequities in order to end homelessness for all. Tom?
Thank you, Jaja. Welcome, everybody. Good morning. The first thing that we have on our agenda this morning is a period of public comment. Catherine, did anyone reach out to you with pre-written public comment today?
No, they did not.
Are there any attendees here in the meeting who would like to raise their hand and be recognized for public comment? Okay, seeing no hand raises and having no pre-written public comment this morning, I think we can close that section of the agenda and move on to our next item. Before we move on to the next item this morning, one thing that this is on me for forgetting to put it actually on the agenda. But the first thing that we should do is we should, is there anyone who'd like to motion for a vote to approve last month's meeting minutes?
I'll make that motion.
So moved.
You have a second?
Seconded.
Wonderful. Okay. Thank you, Eddie and Kelsey. So those will get approved and they've been sent out to you, and we'll make sure that they're, if not already posted on our KCRHA website, that they're up there for everyone for record.
Are we gonna call a vote?
Thank you.
Oh, I'm sorry. I'm sorry.
Okay,
Are there any abstentions?
pardon me.
How about, are there any nays for the minutes? Well, seeing as though there's no abstention and no nays, that means everyone is in favor, and so the minutes pass.
Thank you, Jaja. And I'm sorry about that. Got a little excited, got a little ahead of myself there, so.
Oh, no problem. I think I might have was supposed to do that and forgot. So we got each other.
Great.
Thank you. Teamwork.
Teamwork indeed. Okay, the first thing that I have on the agenda for you all today is a really exciting thing. I wanted to kind of give an update and show you all. So this is kind of like, I know that it was yesterday, so I didn't, and I apologize. You know, the short week, long weekend kind of had me a little bit scrambling here on Tuesday and Wednesday to make sure that we had everything in line. But you should have all received yesterday during the workday both copies of the phase 1 and phase 2 drafts of new coordinated entry assessments for our coordinated entry system. And so what I wanted to do today was kind of walk through the different pieces and parts of those assessments, and then also kind of let you all know what the next steps are gonna be in terms of actually bringing these to the community, and ensuring that the great work that our assessment work group's been collaborating on over the last year actually, is able to reach the community and kind of and get out there. I'm gonna share my screen. All right, so last year, you all voted to have us, I'm gonna zoom in a little bit here. You all voted to have us develop a new assessment for the coordinated entry system to ensure that we were not just prioritizing folks on the primarily the length of time in their current episode of homelessness, but actually use a more robust data set that actually represents folks's needs and vulnerabilities, and kind of doing that coordinated entry best practice of prioritizing people based on vulnerability when we have less housing units available in our coordinated entry system stock than there are people who actually need the units, right? So when you have more people than there is housing available, we need to prioritize. And so how we're prioritizing that is really important. What our work group did, and I've presented on this in the past, and I'll kind of keep it really high level today, is we conducted a landscape analysis of all of the VI SPDAT alternative. So all the COCs in the United States that do not use the VI SPDAT, getting a hold of their different kind of homegrown assessments, looking at them, and using that landscape analysis to inform what are the domains that are the most important to us in our community to ensure that we're collecting information about for prioritization, and developing a new tool, and also using the tools that we already have constructed here, our housing triage tool and housing needs form to inform how we want to prioritize people. What the group decided is that what we want to do is use two phases. So have an initial first phase triaging assessment where we're determining, does someone need, first of all, determining, is this household actually literally or chronically homeless right now? Do they need prevention services? So they're experiencing some sort of housing crisis? Are they literally homeless, or are they at risk of becoming homeless? And so determining that will then inform, do they need prevention, or do they need diversion services? And then if either of those are not going to be able to meet the person's needs in their immediate housing crisis, do they need rapid rehousing, transitional housing, or ultimately, do they need permanent supportive housing? So this is what we're looking at now here is this phase one assessment. And so this is that triaging and identifying, is the household literally homeless, or are they at risk of homelessness? How should we proceed with this person's kind of case in the housing crisis emergency room, if you will, right? So they're coming to coordinated entry in a housing crisis. We're trying to triage what their need is. So we have questions for this initial triage. We need to collect information on who's completing this assessment. Are they a staff person from a regional access point or not? We have fields here to collect information if the assessment is updated. So we want to make sure that people only have one assessment. We don't want to see multiple duplicated assessments in someone's HMIS profile. We want to see one single assessment form, and that form can be updated. If it needs to be updated, then we also need to know who is this other, if it is a novel and new assessor, who is that person updating the assessment? Where is the assessment happening? Is that location a RAP site, or is it more of a community access point as opposed to one of the designated regional access points? We have a section about opening questions. These are the kind of first order of business type of questions. We're doing an assessment with someone. Does this person need translation assistance? If I'm not multilingual and I only speak English, and I'm doing an assessment for someone who does not speak English, do I need to kind of pause here and actually get in touch with our language translation line? So we'll include that information too, so that folks who are completing assessments, coordinated entry assessments, can call the language line and actually have a translator assist them in doing that assessment with someone. Then the next question that is immediately after the translation assistance inquiry is this household fleeing or attempting to flee domestic or intimate partner violence? We're working closely with the Coalition Ending Gender-Based Violence, who operates our DV Hope Line and our domestic violence coordinated entry system in our community, to ensure that are we identifying households who are fleeing or attempting to flee domestic or intimate partner violence, and ensuring that they get connected to either most rapidly the DV Hope Line itself to inquire about the availability of anonymized domestic violence services, and then also connected to ensure that they get an intake for the domestic violence coordinated entry system. And also we have instruction here too, to ensure that if someone does identify themselves as someone who's fleeing or attempting to flee DV or IPV, that their profile will be de-identified in the HMIS to be in accordance with the privacy standards there. So we have those instructions here. And then the next piece in the triaging is the current or prior living situation. The way that we wanted to do this was, and actually we looked for some inspiration from our partners and colleagues down there in Multnomah County in Portland, with really just asking this question as simply as possible: where did you sleep last night? And then all these different responses here ought not be read aloud to the participant taking the assessment. What should be happening is you ask the question open-ended, the assessor asks the question open-ended. Has all of these different descriptions of different types of living situations according to different types of HUD criteria listed in front of them? Listens to the person's answer and selects the choice that makes the most sense. So if I say I slept in a tent in Soto, or if I say I slept at the Star Center, or I slept at Mary Pilgrim Inn or something like that, then as the assessor, my assessor hears that and either selects like an unsheltered situation or a sheltered, a homeless but sheltered situation. And this is a big deal too, because the way that we've collected information on this in our community, I think, at least in my personal experience as someone who used to do coordinated entry assessments, didn't always do the greatest job of explaining to our assessor workforce and our housing navigation workforce what is technically a housed living situation and what is an actively homeless living situation. And so I think being a little bit more clear about this, as you can see people describing what their situations might be, it's going to tell those assessors that, you know, if someone says that they were staying in a hotel or motel paid for without, you know, an emergency shelter voucher, or something that's not paid for by a homeless services provider, depending on how long they're staying there, they're housed in that type of living situation. And so from the jump, you're able to have transparent conversations with folks about, you know, it sounds like you are at risk of homelessness. It sounds like you're experiencing some type of housing crisis. However, right now, given your current living situation, you're neither literally or potentially maybe not chronically homeless at this moment of time. And so just being very transparent with folks and doing some expectation setting about what they're going to be eligible for, right? So we want to make sure that that's kind of very clear and transparently upfront with folks at the very earliest as possible in this process. So you're not asking people a bunch of more invasive personal questions, only to find out at the end that they might not be eligible for resources through the coordinated entry system. This is also in line with our effort to the community to let folks know that coordinated entry is not necessarily the housing answer for everyone who's experiencing either some sort of housing crisis or maybe even situational homelessness. You know, we have access to permanent supportive housing, transitional housing, and rapid rehousing resources really largely, and those are meant to serve people who who prevention and like diversion services have already not worked out to resolve their crisis, and so now they're in a place where they really need they are literally and actively homeless. Their housing crisis is in a place where they're actively on the streets or living in a shelter, or if they've been staying in an institutional setting for less than 90 days, they were on the streets or in a shelter before they were in that institutional setting. So our hope with this is to make it more clear and apparent to this kind of community of housing navigation folks and coordinated entry assessors what types of situations constitute literal or potentially chronic homelessness, and kind of helping to reinforce for folks that, you know, someone might be experiencing a housing crisis. Let's actually, coordinated entry might not have the answer or solution to that housing crisis, but let's have this conversation now so we can actually connect you to the other service that could have support for your housing crisis. The next piece is understanding what the household size and composition is. So this is really understanding, is this an individual adult? Maybe they're married, maybe they're in a relationship with a significant other, but for the purposes of the coordinated entry system, we really look at those folks as individual adults. If folks have children of dependent age that they have 51% or more of custody of, that's when we'd kind of start to look at folks more as a family household type. Or are they a young person, a youth, or a young adult? And so this is kind of where we're establishing what subpopulation are folks members of. And then we have this big disclaimer here, which I think will be critical for folks to understand. And this is also something that we adapted and I really was inspired by our partners down there in Portland and Multnomah County for doing a good job for very clearly calling this out to educate their housing navigation and case management workforce to really understand, like, if they're in a homeless situation, proceed. They're going to be eligible for resources through coordinated entry. If folks are in an institutional setting, but have been there for less than 90 days and were in a homeless situation before, then okay, we can proceed. Otherwise, you know, if folks are in a housed or institutionalized setting and they've been there for longer than 90 days and they were not homeless before, we're not going to proceed with the rest of the assessment now, because we don't want to take this time for someone to realize only that they're not going to be eligible for the resources that are available through coordinated entry. And this is that moment where we'll train and develop capacity for our coordinated entry assessor staff to say, how do we ensure folks are connected to diversion? Like, this is that moment, or excuse me, sorry, prevention, because diversion is meant to serve people who are literally homeless. Prevention is meant to serve people who are at risk of homelessness, right? So we want to make sure that if people aren't literally homeless, and they're at risk of homelessness in this triage section of being in the coordinated entry emergency room of their housing crisis, we're going to triage and make sure that we're starting to have conversations with them about what's the right resource for you to get connected with. And then this is where the actual assessment starts. So we have some script, also disclaimer, there are going to be some more edits to this, and that's why I'm talking with you about it now in May. We'll kind of get into this more in the next steps, but the script is one piece that still needs some work, and I gotta keep working on. So I just call that out because I'm excited about continuing to develop it. But we'll ask folks about their income. So this is gathering information about, are you connected to any type of income source? And we have, actually, this is from our current coordinated entry enrollment process. So the assessment work group said, Tom, we actually like the way that the coordinated entry system gathers information about folks' income right now. So we want to keep that. I said, that's great. That's wonderful. So we're keeping that. We have questions about health insurance and non-cash benefits. And then we get to this section here where we're still kind of working out a little bit, rapid rehousing is a low barrier intervention. It does not require folks to have income. And also we know the way that those programs are administered and managed in our community right now, that the folks who are probably going to have the highest likelihood of success being more rapidly transitioned off of a short-term subsidy are people who will be able to take over a private market rate rent cost on their own. And so here we're working out some questions about how do we determine what are the different data points that are important for us to know to prioritize people for rapid rehousing, both holding this idea that it's a low barrier program that doesn't require people to have income in order to be eligible. But how are we ensuring that we are not setting folks up to fail, right? We want to make sure that people who are getting connected to these programs, that it's actually going to be something that meets their needs. And so, Kelsey has used this term in the past, and it's really stuck with me and stayed with me. And I think it's really important is that we're not talking about what people are the right fit for a program, and also too, even using these words like fit, it's more like, how do we make sure that the programs that folks who are matched with programs, that the program is actually supporting them in their long-term sustainability, and making sure that, hey, they've been in this housing crisis and maybe they've been situationally homeless right now, but through being connected with this program and the resources that it has, they're going to be, they're not going to quickly return to another housing crisis soon, right? That this program is going to actually support their thriving and well-being, over time. So we're working out some questions there still. I have this demographic piece stricken from the record here, but I have it kind of that in saved changes. The reason why is to let you all know that demographic information is going to be something that's important with how we are kind of like assessing folks' need. And also, we collect people's demographic information on their HMIS face page. So we don't need to take people's time by asking them more questions about their race, ethnicity, gender, sexuality, veteran status, whether or not they are an enrolled member, so political status, too, like, are they an enrolled member of a federally recognized tribe? Those are all things that we ask people on their HMIS face page. And so in the script, we'll have specific instruction for the assessor to say, before we jump into this assessment, make sure that you've gone over with this person that all their demographic information on their face page is accurate and up to date. And now we get into questions about folks' health. So asking them if they have any disabling conditions or health conditions that would impact their ability to secure housing. We have some language in here calling out that these don't necessarily specifically need to be diagnosed. And we have some examples of what different types of physical or mental health conditions, vision or hearing impairments could be. We will have some questions that will populate if someone's indicated that their household type is family, then we'll have some additional questions pop out for folks to answer about the different household members of their family household. And then some additional health questions. And these were really the questions that the group said were just enough to need to know that if folks would probably be more of a service match type for rapid rehousing or transitional housing, meaning that the level of intervention they need to resolve their housing crisis is not as deep as permanent supportive housing. And we didn't want to overburden folks with questions about their health. That's more personal information here. We just wanted to ask the level of question to determine, is this probably someone who's going to be able to be served by a rapid rehousing or a transitional housing or even a diversion intervention? If so, great, we know that. If through the answers to these questions, it's sounding like this person might need a more robust intervention to resolve their housing crisis, then this is where we're identifying there might need to move on to this phase 2 assessment that I'll talk with you all about here in a moment too. We collect information about folks' eviction history. This is purely just to kind of understand people's barriers, right? This isn't in any way, shape, or form to perpetuate or say to set folks up to think that maybe these are going to continue, you know, that we're trying to set a barrier for them by understanding their eviction history. It's really more to ascertain the level of information that's appropriate to know, you know, what types of barriers or challenges might you have to being able to be housed again. And this is also another thing too, where if someone's looking like they have some substantial kind of eviction history and past housing debt, that's also something that's flagging for us that maybe a rapid rehousing or a transitional housing intervention might not be sufficient for a household with some of those significant and substantial barriers. And they probably are going to need a more robust intervention because even if they were to be matched with a rapid rehousing resource, these are something as we see with some of these programs that it might be difficult for them to actually obtain a unit once they're enrolled in a rapid rehousing program, because these types of past housing barriers could present a challenge for them in securing housing. We ask about some legal challenges, similar here with the eviction history. And then we ask people about whether or not they would benefit from culturally specific services. And we have a very important flag down there that's to say, you know, it doesn't, if you say that you are interested in culturally specific services, this is not going to make you ineligible for maybe not by for type provider services. This is also not necessarily guaranteeing that you will be matched with a by for provider that matches your identity. And this is also not necessarily saying that you'll meet final eligibility with by for providers. This is purely just to gauge, is that something that you're interested in? And then we ask people about their social supports. Do they feel that there's anyone that they can count on or assist them or help them when they need? This is, you know, a really important thing to understand too for some of that kind of like diversion triaging and rapid rehousing triaging. Do you have a safety net? Do you have a social support safety net of people who are going to be in your corner while you're in this housing crisis to support you and help kind of ensure that you'll make it through? And again, something that can be an indicator of if folks are expressing that they really don't, you know, that could also be a sign that maybe they are going to need a little bit more of an intensive intervention. Then we ask people about their contact information, and we have some kind of admin questions here, the date, the location, all that kind of stuff. So that's this first triaging assessment. I'll keep my screen shared, although I've been doing some presentation in the community recently, and I've kept my screen shared, but people have asked me to stop. I'll keep it up just in case people have specific questions so we can reference, but if you want me to stop sharing so we can kind of all see each other better, just let me know. Okay, it doesn't really sound like many folks have many questions anyways. Devin, yeah.
Yeah, thanks, Tom, and thanks to everyone who's this is a lot of work and thoughtfulness that has gone into preparing this. I really appreciate that. For the culturally specific services, I was just wondering, there's that drop-down list. Is that going to be limited to those, you know, identities, or would it be
No.
possible? Okay. Cool. Just wanted to make sure. Okay, great.
Yeah, if you can think of any others that you would think would be nice to be included, please let me know. My inbox is open. And again, this is kind of like uh, a pre-sample cursor. This was a nice kind of informational preview for you all. It's not till next month that I'm going to be asking this group to endorse, and we'll kind of get into some of these next steps here. But to endorse kind of moving forward with bringing a draft. And the other thing that I'd like to say too is something that the group's been talking about over the last year with this process is we know that there's always going to be a need for continuous quality improvement with something like this. And my real ambition and aspiration with this group is that once we bring this new assessment to the community, for the folks who've been a part of the work group, I'd love for them to stay involved. I want them to stay involved. Their collaboration, input, and support has been, we wouldn't be here without it. And I'd also like to open it up to some wider members of the community too. I've been in touch with folks from Healthcare for the Homeless Network, the Behavioral Health and Recovery Division of King County, jail health services, and different elements of public health. Lots of folks who I think would be great for us to, and actually the Austin COC down there in Austin, Texas, have a what I think is a really admirable model where they quarterly look over the data of how folks are responding to their kind of local homegrown assessment questions and quarterly convene their continuous quality improvement work group with a diverse array of stakeholders to say, are there some things here that we need to tweak? Do we need to tweak how we're asking about people's health? Do we need to tweak how we're asking about the culturally specific services? So I'd really love for this to be as nimble as possible with saying that if I'm convening that group and there's folks saying like, well, what about ensuring that this type of identity group or affinity group, should that be included in the culturally specific services too? That we can add that, and we can always be kind of like not treating this as a necessarily a living document, but really something that quarterly, every half year, every year, if we're needing to say that we need to make some changes, that we can be nimble and do that. Okay, let me see, is there a question in the chat, Catherine?
No, it was just be right back.
Okay, oh, nice, okay. All right. So to keep us moving along, now I'm going to share a copy of the second phase. So we are let's see. Bigger. So someone has gone through this initial triaging assessment, has been identified as someone who might need a more robust intervention like permanent supportive housing. And I think something that our work group talked a lot about is that our local system in the past, and even looking across the country to these other communities that use their own kind of VI SPDAT alternative homegrown assessments, something that we really saw as a gap that we didn't see met really anywhere else is all of these triaging assessments and different coordinated entry assessments do maybe a good job at what our phase one assessment is doing of determining, you know, does someone need PSH? Do they need rapid rehousing? Do they need diversion? Do they need transitional housing? Sure. But not necessarily do they do a great job at actually prioritizing high needs individuals for permanent supportive housing. So we remember with the VI SPDAT that even folks who had a quote unquote high VI SPDAT score, there was still a lot of variation in terms of that what we saw in our community and what our previous evaluations and everyone's professional experience with those assessments revealed was that someone could have maybe a high VI SPDAT score, but that didn't necessarily mean that permanent supportive housing was really the appropriate intervention for them to resolve their homelessness crisis, right? And so the biggest and what I heard from the assessment work group, from members of this committee was, Tom, we really want a way to get a little bit deeper at ensuring that, you know, we have a big pool of folks who perhaps permanent supportive housing could be the appropriate intervention to resolve their chronic homelessness. But we want to make sure that we are prioritizing them accordingly and that we're actually getting a better idea and understanding of what their needs are. And so that's kind of what brought us to this place of two phases. And that's something that, you know, HUD talks about, HUD Exchange talks about as being for all of their resources and technical assistance support around coordinated entry is that's something that communities can do is these different triaging phases of saying, you know, identifying first, we're in the emergency room. What do you need now to ensure that you're getting connected? If it's looking like you are chronically homeless and maybe have multiple disabilities, let's do another assessment and kind of see to be able to prioritize amongst that specific population. And so I really have to give a big shout out to our partners at the Downtown Emergency Service Center, because really this is kind of an adapted vulnerability assessment tool, kind of like script and questions. These are largely pulled from the vulnerability assessment tool, and I'm making sure that I am citing that as a source here. I got my little footnote, you know, that it's adapted from their questions. This community has long talked about how that tool really does, and this isn't just in this community, but really nationally and internationally, that tool is kind of a bar setter in terms of how are we looking at high needs individuals and ensuring that when we have limited resources like shelter beds or permanent supportive housing units, that we're prioritizing those who really are the most vulnerable in our community, and kind of like ordering in that capacity and fashion. The big drawback, at least what we've experienced in our community, the barrier, not drawback, excuse me, but barrier I would say is that it's a robust tool. It requires a high level of training, and it has a lot of different measures for implementation to ensure that the tool remains valid and reliable. And so that's just something that our community has tried over the last decade to implement writ large across the region, for saying, let's train up an assessor force to be able to administer the true vulnerability assessment tool. And there's just been a lot of barriers and challenges to doing so in a way that maintains that reliability and that validity of the scores and the tool itself. What we have done here is taken the good pieces, the excellent pieces of that, which is the way of the domains of the tool and the way that it asks questions. And we've done our best to make the responses to these questions yes, no, or provide people with that type of model that I showed you all with the current and prior living situation, where we will have a drop-down suite of options for people to choose from. The assessor can ask the participant an open-ended question, listen to their response, and then choose from one of the pre-selected options, choose one of those that best matches, and maybe there's even multiple that best matches the person's answer. This way, we'll be able to create a scoring matrix for this based off of yes or no answers, and based off of how people respond to those more open-ended questions with a drop-down list, and actually be able to kind of get something that is scoreable and can prioritize people and does a better job at this than our just triaging assessment, but also doesn't involve big text boxes and a kind of like big scoring process and procedure. So we start with some questions to screen folks. And the goal of this is really to look at, is this participant also someone who their needs even surpass the scope of services for permanent supportive housing? So is this someone who is not able to transfer from their cot, bed, or mattress on their own? Do they need the physical assistance of people to lift them up off the floor? If they're staying in an encampment, are they not able to get off of their sleeping bag on their own? Are they able to move, or the medical term ambulate, on their own? Do they need a mobility device? Can they transfer from their bed without assistance? Do they have a history of traumatic brain injury symptoms or dementia? Do they use a colostomy bag? Do they require tube feeding? Yes or no answers to some of these questions are going to let us know right from the beginning that maybe also the conversation needs to matriculate into, does this person need to go to the hospital now? Or do they need a skilled nursing facility or an adult family home? Our team actually receives a lot of those mobility requests, transfer requests from different housing providers, sometimes highlighting that people need a increase in service because of some of these different types of criteria here. And what our team likes to do or does in those situations is let folks know, it sounds like this person really needs even a higher level of care than even permanent supportive housing can provide. Permanent supportive housing assistance staff aren't able to, lay their hands on someone and help them off the floor if a person's not able to stand on their own, or be there every single day to help a person transfer out of their bed so that they can make it to a toilet. If there's someone who's even living in permanent supportive housing that needs that level of intervention, then they might even need a higher level of service than PSH. So we're just trying to kind of screen that and set that expectation for folks right off the jump. We have some similar introductory info here. And then we go into the survival skills, basic needs, and organization and orientation types questions. So asking people, how did you hear about this assessment? How folks will respond to that question is going to reveal, how kind of connected are they to different systems. What we're trying to kind of suss out and determine here is this someone who, while they might need a really high level of mental health or housing case management assistance, are they really actually not connected with providers at all? So we're starting to get kind of an idea of, is this someone who is high needs and actually, because of how severe their needs are, they actually avoid engaging in services? We asked folks about what kind of services they need help with, whether or not they sleep in shelters. And this isn't necessarily to prioritize shelter stayers over non-shelter stayers, non-shelter stayers over shelter stayers. This is, again, to get at, what types of choices are folks making and how is that impacting how vulnerable they are or not, right? Asking folks about where they typically get food. Are they getting it from homeless service providers? Do they know how to navigate the crisis response system? Or are they dumpster diving? Or are they relying on maybe a community that, sometimes they get food from different members of that community, but also really take advantage of them? We might call that like a detrimental social network or something, so getting at that type of vulnerability. Are they able to get their hygiene needs met, do their laundry as often as they need? Where do they go to get those types of services? We'll go into some more questions about medical and indicated mortality risk. Here again, we actually don't ask that many questions. It's really just kind of getting at, does this person have a terminal illness or some sort of chronic, ultimately terminal illness? Do they have cirrhosis? Kidney disease, renal failure, heart disease, asking folks, when was the last time they saw providers? Have they needed to stay overnight in the hospital during the last year? And do they take any medications? Then we ask folks about their mental health. Are they currently experiencing any mental health concerns or conditions? And then really trying to get at, are these things that are like anxious thoughts or a depressive mood? Or are we talking about some real serious symptoms that render folks more vulnerable in the community? Do they experience suicidal ideation? Do they have severe delusions or paranoia? Do they talk to themselves? Are they highly distractible? Different types of mental health symptoms that render folks a little bit more vulnerable and maybe more highly engaged with our crisis response system in the community. Do they agree? Do they have a diagnosis and do they agree with it? Different questions there that can reveal someone's level of insight into their own mental health. Are they connected with care providers? Have they needed to use any crisis services for mental health or emotional support? Have they been hospitalized for their mental health issues? Have they ever had their mental health competency raised at trial? That's something that's an important thing to determine. Then we have questions about people's substance use. Do they use substances? If so, how? Different methods of administration, how people use substances can reveal a lot about how vulnerable they are. Do they reuse needles? If they use needles, do they share them with others? Do they know how to use their drugs of choice, or do they rely upon people who might take advantage of them in order to even get those needs met? Sometimes people aren't able to inject themselves, and so maybe there's a partner or a friend that actually they really are trying to get away from, but they rely on that person to kind of help them out with these types of things. That's something that keeps them closer to an abuser. These are the important types of things to know about determining some vulnerability here. Social behaviors. How well are people able to tolerate being around other people? These are also important things to know in determining vulnerability. And then finally, people's homelessness history. So just a very simple question. We know we've asked people about their current or prior living situation. This is a little bit different. The reason why I'm keeping this question is because it's actually a little bit different than just someone's immediate current or prior living situation. This is the chance where we're asking folks, okay, maybe this episode of homelessness, you were housed at Plymouth 2 years ago, but when was the first time you ever became homeless in your life? That there's a lot that can be said there for folks about, I volunteered for the point in time count earlier this year, and it's always really humbling and enlightening for me to see when I ask folks this type of question doing the point in time count interview. You hear a lot of times for people who've been chronically homeless that the first time they ever became chronically homeless was when they were young. And that type of information is important to collect. So that is the whole assessment. So again, a little bit of time for some questions if anyone has questions or comments. Jaja.
Yeah, I didn't comment on the first section, but I meant to because I wanted to say how I thought that was so very important that you took into consideration people and where they were at right now. And well, no, the first part was, let me back up. It's because people I think it brings more clarity to what coordinated entry is and what it can do. Because I think for so many years, people have been thinking coordinated entry is like the housing authority or something like that. And they sign up and people wait and don't realize it's not for them. And so they've wasted a lot of time. You know what I mean? And so I feel like this way people can move on and figure out other resources that they can get help in. And so I really felt that first part was really important. And that's what I wanted to say about that. And then about this other thing, the second page part of it, I like the whole thing, especially the triage where it says, hey, if you're not in these certain situations, then this isn't for you. And, I'm not wasting your time and we can move on, right? That's beautiful, I believe. And then on the second part about the drug use and things. I like the fact that, which you didn't say, but I read it, that do you have a counselor? Do you want to seek treatment? Whatever kind of thing. You know what I'm saying? Those things, we want folks meet people where they're at, but also, you know, just to give more information to other things. We're here to help. And I feel like those kinds of things, hey, well then that's another way that the provider can help them if they do want to get counseling or whatever their need is. You know what I mean? If they want to get off uh of the drug but just don't know how. And then you're talking about the people who are most vulnerable that may be connected to an abuser because they need them for this, that, or the other thing, you know? And so I like the way that y'all came together in this work group and came up with this fantastic piece of work. That's what I wanted to say. That was my comment. It wasn't a question.
Thanks, Jaja. Yeah, I appreciate the feedback. If no one else has any comments right now or questions, one thing that I'll just say is, like I said, this is like an update, sharing these with you, not asking you to endorse or vote on anything to move forward today. Wanted to kind of begin socializing the content of these assessments. I've sent them to your inboxes, and please, if nothing's coming up for you right now in this moment, but if there are any suggestions, ideas, like Devin, you had that question about the culturally specific services, please send me a message. I am so, and actually that's a great segue to next steps. So, right now, I have sent these assessments out to folks internal here at KCRHA to get the wealth of expertise and knowledge from my colleagues. And that's why you can kind of see there are a lot of comment bubbles in there. I've been getting lots of fantastic input from all the wonderful folks that I work with saying, hey, what about this? Have you thought about phrasing it that way? So sharing it internally with KCRHA, my team, sharing it with my team, getting their input and feedback, and sharing it with public health. So several different public health groups, the Healthcare for the Homeless Network, Jail Health Services, and like I said, the the King County Behavioral Health and Recovery Division. So getting some insight and support back from them. I had some really great conversations with folks there at Be Heard, really talking about the system that they use to prioritize folks in their crisis response systems too. It's called the Locus. So they have a way that they are triaging folks' needs for saying like, okay, we only have this many inpatient psychiatric treatment beds right now. And it's a similar type of systems question, right? Like there's more people that need access to this inpatient psych treatment. We only have this many number of beds. They use their data sets to determine how they're going to prioritize folks. So they've been sharing some of that information with me. I've been sharing this assessment information with them, and we've been really collaborating and working together on how can we draw some similarities here and ensuring that there's some more alignment between our systems. So that's been great. Yeah, the Healthcare for the Homeless group, the outreach and housing nurses group has been really collaborative and interested to work with me to give feedback on some of this medical vulnerability pieces as well. So that's kind of the phase where we're at now. The drafts are almost there. I'd say like 95% of the way, just really getting these last kind of tidbits of information from folks. And I'd really love to include you all, like please know that the door is open, the invitation for you all as our CEC members too. Read them over, let me know if you think we're missing things. Yeah, Mustafa.
Just a question, you say locus, this is the locus for the things for functional status score, risk of the harm cells and comorbidity, recovery environment, recovery and treatment and recovery history. This is the locus you talk about it through NAVOS for the
I think
psychiatrist
so.
evaluation?
I think so. I don't know if maybe Navos developed it. I'm not as familiar. I'm only, introductorily familiar with it over the last couple of months. Perhaps Navos developed it. But I know that Be Heard, for all the programs that they're funding, that's what they use. And it sounds like we're talking about the same thing, Mustafa. Yeah.
Okay, yeah, thank you.
So we're gathering this feedback, kind of like ironing up the last details here. Next month, when we meet in June, it's either the 26th or the 28th. Let me pull it up right now.
It's the 25th.
The 25th. Okay, yeah. So next month, when we meet on June 25th, there will be a vote on the agenda. I'll have earlier this time send you the final drafts of these two assessments for you to review. Get any last kind of concerns, last pieces of feedback in there. And then I will be asking you to vote to endorse that we move forward with beginning to implement this in the community. Another update is I've still been keeping in touch with our colleague at the University of Washington Information School. His name's Pele Tracy, and he's still on board to conduct an evaluation of this assessment. I think what we would first move to do is before we would be to bring this assessment to the public and kind of have it go live, so to speak, as the actual coordinated entry assessment. What we'd want to do is we'd want to pilot it with a small group of like real participants though, and get some feedback. How is this landing with folks? How is this landing with assessors? How is this landing with participants? And not necessarily to judge or evaluate how effective the tool is at matching folks to housing and all that stuff, but really just how is this landing with folks, participants and assessors as an assessment tool. My hope would be that pilot phase wouldn't be very long, just as much time as kind of my team of experts on how to implement that type of thing would say you really need in order to get some good feedback on thumbs up or thumbs down. Are we ready to roll this out? I'd really love to roll this out, go live with the community as soon as possible. I don't want to attach a timeline or a date there, commit to anything just yet, but I want you all to know that I would love to see it implemented with the system as soon as possible, because that also means that then we're going to be able to change how we are prioritizing people for housing in coordinated entry. And that's going to be a huge deal. We haven't changed how we prioritize people for CE since 2023. And it's been a long time now of what was meant to only be an interim form of prioritization, primarily based off of length of time homeless. And we're kind of on the precipice of being able to change that. And so the evaluation with Pele would really be looking at, even once this is implemented, how is this new process compared to this old process where we would enroll folks in coordinated entry, ask them to complete the very small HTT and complete the HNF. That type of system we've been running for a few years. He'll start to do some data collection, qualitative data collection on how that process is for folks right now. And then when we go live with this, he'll continue to do data collection and see how is this new process landing with people, and is this an improvement? And that's where we really see, is this an improvement upon what we've done in the past? And he hopes to write a scholarly article kind of talking about this assessment and this process and kind of what we've done as a community to say, hey, here's what we were doing in the past, and here's this new community process that's brought a homegrown assessment, and now this is what folks are saying about it. And so that's an exciting piece too. Some other practical logistics are working this not only for revision and feedback through KCRHA, but also KCRHA leadership approval. So working it through our chief programs officer, office of the chief executive officer, so Kelly's office, and getting their approval, signing off to say, hey, this is something that we as KCRHA endorse, should be moving forward and going out to the community. And then also our COC board. We are on the agenda for a COC board meeting next month to kind of give them a similar update to where we're at in this assessment development process. And then finally, ultimately in July, if KCRHA is on board, if the coordinated entry committee endorses and is also on board, then let's go ahead with the COC board in July and ask them to vote to move forward with this piloting to see like, is the tool actually kind of gonna land with folks the way that we want it to, and then bringing it live to the community. So yeah, that's really exciting. I can't wait to continue moving forward this process with you all, but hopefully that's some helpful illumination about kind of how the pathway forward looks for us here. Does anyone have any questions or comments about that? Okay, hearing none, that sounds good. Awesome. The next thing that I wanted to update you all on is the Catholic Community Services Coordinated Care Agency Sacred Heart Family Shelter. It's the current location that it's at had been slated for closure, and right now our teams are working closely with CCS and the city of Seattle to identify new locations, but one has not been identified yet. And so our team, with you all having endorsed in the past programs that are slated for closure, just wanted to update you that our team at KCRHA communicated to the Catholic Community Services team with Sacred Heart that we would approve in the family space, those families being prioritized for housing to ensure that there's no one, the hope is that a new location is identified before this current location has to close and that no one will be displaced. But just in case, if there are any families that need referral through the family space and coordinated entry, that they are prioritized for housing. So I just wanted to update this group about that. Any questions or comments about that?
Yeah, Tom, I was gonna say, do we know when that's slated for closure?
Yeah, let me check.
And do we know how many people that is?
I don't know. I don't have a
I
copy.
know it's 9 families
Okay.
Oh,
is
thanks,
what their
Eddie.
capacity is.
Okay, thank you, Eddie. I figured you'd have that information.
I don't remember off the top of my head when the lease expires, though.
Okay. And that's
But
what
I think that's
a
what
lease
Tom is.
expiration.
Yeah, it's a lease.
Okay.
Or they're selling the building, or they want to sell the building, or something like that.
Okay.
And just to be clear too, I think the goal and the hope, and I believe all parties are on track to say like the goal should be met, that a new location is identified first. But just in case, since one hasn't been found as of right now today, that we're keeping this prioritization to make sure that no one's displaced. The program's set to close on June 15th.
Okay.
So it is imminent, but this is something that we've been working on them with over the last several weeks too. So I'm just letting you all know that this is happening now, but it's been kind of also happening in the behind the scenes.
Well, that's a beautiful thing. I'm just glad that we can step up and step out and be there to support each other, in collaboration instead of silos. Wait until the last minute and folks fall through the cracks.
Okay, well, yeah, Chair Floyd, those are the end of my 2 agenda items. So I'll yield it back to you to kind of take us home.
Well, does anyone have any questions or comments about our meeting today? Or have anything they'd like to share?
All right. So,
And can we just elevate Sherry's comment in the chat? Hello, I really like how this have came along and with more clarity and understanding for folks and providers, which I agree 100%, Sherry. Because the clarity and I finally in all these years understand the definition of coordinated entry. I mean, that's what I feel like. I feel like all the times I've been in coordinated entry and working in this space, I really not got a clear definition of what its role is in the community. You know, I mean, I hear PSH, I hear rapid rehousing, transitional housing, what do you call it? Section 8 housing, all that. I didn't know that it wasn't all one big thing. And so now I'm glad that we have the clarity and understanding, and I like this tool that we're coming up with. I really appreciate the work group and all the providers and the team who came together to work to make this a better tool for the community, right? And for the people who work it, because we don't want to get, fatigued, compassion fatigue, helping folks. I have a passion for helping people, but you can get tired in helping, if you feel like there's no help for the helper, right? And the help for the helper is getting clear understanding of what we can and can't do, right? And then those
Yeah.
folks who need more help and more care can, if there's a different avenue and lane for them to journey down, and other people can come on board and help them out. So those are my last words. Does anyone else have anything else for the good of the order? Seeing none, knowing y'all are so very, very busy because we have an overabundance of homelessness out there. So I'm going to give you back your time. Yield it back. It's 11:19. I'd like to call this meeting to an end at 11:19. So, meeting adjourned.
Thank you, everybody.
Thanks,
Have a
y'all.
good day.
Everybody.
Thank you.
Thank you. Have a good day.
Bye. Catherine, I have a question. So in July, HCHN, we're not doing any